change the volume,
Yeah.
this one, and if you want to change the lights, you hit environment and 2 or 3.
Oh, I'm not going to get that fancy. Let's see. It's on. We'll lower this. Huh? Okay. Good morning, everyone. How am I doing on volume? Are we okay? Good. Well, it's good to be back and see you guys. So today we're going to talk about cohort studies, but let me make a couple comments about the workshop we have on Friday. So I have loaded 2 published papers on LCMS for you to review before you come into the lab. Don't panic. There's going to be a lot of stuff in the papers, the statistical stuff and all you're not going to be able to follow. But I'd like you to read through the papers with the concept of, what was the research question, the design, how did they actually get this study done? Don't get yourself too wound up in too many of the details, okay? Because there's lots of stuff in the papers we haven't dealt with yet. But anyway, try to look them over. And then for the questions, I should have them up either this afternoon or tomorrow, okay? But you really, other than reviewing the papers, you don't have to do anything before you get to your small groups, all right? Okay. So again, we're going to talk about cohort studies today. And if you remember only one thing from this lecture, it's a cohort study is a prospective study design. No matter how many other words you hear, and you're going to hear several, a cohort study is prospective in design, okay? And I'll follow up with that in a minute. No disclosures. Okay, so today we're going to talk about how you might set up a cohort study. We're going to talk about the strengths and weaknesses of a cohort study, more strengths than weaknesses. We'll talk about the measure of association that you use in a cohort study, and then we're going to contrast a cohort to a case control study. So you should, at the end of this presentation, be able to decipher the differences in those 2 study designs, because some people get them confused. Okay, so you've seen this slide several times before. We have gone through, a couple weeks ago, all of these descriptive study designs, and we talked about a case control study, which I had said was more of an analytic study, meaning it was driven by a hypothesis. It wasn't descriptive in nature. And today we're going to talk about a cohort study. So we're now getting into some pretty serious research that really can provide very important, compelling data to answer a research question. And so this is another figure that sort of lays out study design. So before, everything was observational and descriptive, and then we moved to observational and analytic being a case control study. And here, the other observational study that is analytic in type would be a cohort study. That's what we'll talk about today. And then in February, we're going to move over to the categorization of experimental studies, which are randomized clinical trials. And we'll talk about them. But next to a clinical trial, which is really the best study design you can do to answer a research question, and to infer causality. Other than that, the next best thing is a cohort study. And I would dare to say that although a randomized study is better, it's the usual thing. A poorly conducted randomized study will not be as good as a very well-conducted cohort study. But the cohort study lacks randomization. It is still observational, what we call a natural experiment. And so that's the big issue. So let's go through how we would set up a cohort study. The first thing you're going to do is select a group of subjects at risk for something who have been either treated in a particular way or exposed in a particular way to a factor of interest, and a group non-exposed. So you decide what it is. So the old example, smoking and lung cancer, we could take a group of smokers, that would be our exposed group, and a group of non-smokers, that would be our non-exposed group. So you can select your sample that way. Or the other alternative in a cohort study is to identify and recruit a large group of subjects and then test them or evaluate them and divide them into a group of exposed and unexposed. So, for instance, if you're looking for an exposure that is less common, you probably are going to have to go out and find people with that exposure and enroll them, and then enroll a group of unexposed people. But I think we talked about in the introductory presentation, I mentioned the Framingham study. That was a cohort study. And in Framingham, they did the latter option. They just went out and recruited adults living in Framingham, Massachusetts. And because the primary exposure they were interested in studying was hypertension, and they knew in older adults hypertension was pretty common, they knew they'd have enough people who were exposed. So they just got everybody together and then divided them into exposed hypertensive patients and non-hypertensive patients. So either way will work. Depending on what your exposure is, you may plan to do one versus the other. Okay, so you have an exposed group and an unexposed group. And then you're going to collect some additional information besides exposure on these individuals. You want to know some additional factors that may bias the results of your study, or you may have to adjust for in the analysis. So for instance, if I was doing a cohort study on smoking and lung cancer, I would certainly want to collect people's age, right? Because we know that age is going to affect who gets cancer and who doesn't. Age is one of the biggest predictors of cancer risk. And so if I'm comparing a smoker who is 35 years old and a smoker who's 70, I would want to be able to take that age into account when evaluating their risk of developing lung cancer. So you're going to collect some additional information, and then you're going to follow your two groups, exposed and unexposed, forward in time to determine who has the outcome of interest. So I would follow my smokers and non-smokers over many years and determine who developed lung cancer and who didn't. So that's an overview of how we get a cohort study started. So again, another figure where we select exposed and non-exposed, follow them forward, and identify who's developed the disease and who didn't develop the disease. Obviously, most of the time, if you think about the exposure as being a negative or a risk factor, you're going to expect a greater proportion of the exposed patients will develop disease than the non-exposed. So here is a table where I've just flipped the format. So this, of course, is our typical 2x2 table. Now remember in a case control study, we had cases here and controls here. And then we went back in time and decided who had the exposure of interest. This time we're starting over here. We select our subjects based on whether they're exposed to the risk factor of interest or the treatment of interest or not exposed. Just a little clarification here. You will sometimes hear people, not usually an epidemiologist, call this exposed group your cases and these your controls. Or they'll call this group exposed and this group the control group. I would encourage you to use save the word control for a case control study. So stick to the word exposed and non-exposed. That usually implies to someone that you're doing a cohort study. You may occasionally hear me call this exposed and this be your comparison group. You could use that term, but don't use the term control group, okay? And so we again have identified these cells as A, B, C, D. Stop me if you have questions, okay? All right, so what are the assumptions in setting up a study this way? Well, there's two major assumptions. The first is that the exposed and unexposed group are both representative samples of the general population that you want to study. So again, if all my patients are African American, the only thing I can represent or generalize to is an African American population. Or if I want to generalize to the general population, a target population of US residents, then I better have a diverse group of subjects, some who are white and some who are minority individuals. So again, this assumption is what links you from your study design to generalizability to your target population. And then the second assumption is one that some people have a little trouble with, and that is that we assume that the exposure that we're studying is never, that the non-exposed group never are exposed to the risk factor. So for instance, if I start a cohort study of smokers and non-smokers, I make the assumption the people who come into my study and are identified in the non-exposed, non-smoking group, I make the assumption that throughout the follow-up, the prospective follow-up, that they do not start smoking. Of course, there's mistake. Of course, that isn't perfect, but most of the time it's true. Did I see a hand here? Yes. Most of the time you do not. If you're doing a really, a very abrupt study, like let's say I'm looking at the clinical course of people who have a heart transplant versus people who have the same heart problem but don't get transplanted. And if the people in the non-exposed group, meaning they didn't get the transplant, eventually get a transplant during follow-up, you might delete them from your sample because that's such an obvious acute intervention. But something behavioral like smoking, we usually just leave them in. So you're basically what you are, how you are characterized at the beginning is how you remain in the analysis. And you understand that a few people probably, you're going to have smokers who quit and you're going to have non-smokers who start smoking, but it's usually a minimal number of subjects, and the result of that error would be that it would be what we call bias the risk estimate to 1. So it's going to be more likely that you will have a negative study than a positive study if you have a lot of that crossover. And that's considered a lesser sin than saying that there was an association when in fact there wasn't. So we usually just leave them in. Once you enroll subjects in a study, and when we get to randomized trials, I'll talk about this more, you know, if you say I entered 100 patients as subjects in the study, you really should include 100 patients in your analysis. And if you don't, in your manuscript, you should identify in detail what happened to those people. You know, so I might say 2 people got a heart transplant and I excluded them from my sample. But the smoking is just harder to track day to day. Okay? Okay. All right, so where are we going to get this exposure data? Well, it's from the usual suspects. You could go to the medical records and identify people who had some exposure or even some condition. Maybe I'm looking at death related to diabetes, and so I would identify people who were diagnosed as diabetics in their medical record and a group of people who weren't diagnosed. Don't be sort of confused here or tricked. Your exposure could be a disease, not necessarily a risk factor. The disease could be the exposure, and you could have some other outcome of interest. So, for instance, we might have adults who had Hodgkin's disease as children and adults who didn't have Hodgkin's disease, and our outcome females, and our outcome could be adult breast cancer, because kids with Hodgkin's disease had a lot of chest radiation, and so the girls are at an increased risk of breast cancer. So just because it's a disease doesn't mean it's the outcome. It might be the exposure. Okay, so medical records, you could get information from the subjects themselves. You could interview them, do questionnaires. You might identify them based on a medical examination. So in Framingham, when they wanted to identify people with high blood pressure, they took their blood pressure. We could run some biomarkers and measure some parameters that we're going to use as exposed and non-exposed. And we have an example of this in our lab on Friday. Or you might have measures of the environment. I might choose a group of people who live in an area of the country where there's a lot of smog and terrible air quality versus a group of people who live in the Colorado mountains where the air is very clean. And I might be looking at respiratory conditions as my outcome. So there's lots of places to get the data. And so once we identify who's exposed and who is not exposed, we follow them forward to determine who has the outcome of interest. So in a cohort study, you want to make sure you define your outcome very clearly. If it's a disease, you have to have, again, very specific definitions of what that disease will be. And we talked about a similar issue. This is actually very much like when you do a case control study. I talked about defining the case, defining what the disease really is. And so it's the same thing in a cohort study. You're going to, however, exclude subjects known to have the outcome at enrollment. So, of course, this is something you like to do while you're entering subjects. So, for instance, if I'm doing a cohort study of smoking and lung cancer, if I have somebody who has already been diagnosed as having lung cancer, they can't be at risk of lung cancer. So that patient already has the outcome I'm interested in studying. They shouldn't come into my study. Occasionally, though, you will miss something. You'll do some assessments to make sure the patient doesn't have the outcome of interest. And then something will turn up shortly after they are enrolled in the study. Usually what we do in a cohort study is we'll enroll subjects and we'll say anybody who develops the outcome within a year of enrollment, because frequently you're going to find out these studies go on for many years, those patients would be deleted from the study. That's a very common thing with cancer. So, for instance, with lung cancer smokers versus non-smokers, if somebody was diagnosed with lung cancer within a year of entering my study, they probably had lung cancer when they were enrolled because it grows in most situations in the beginning, it starts very slowly with a few cells. And so, in fact, probably this person was not at risk at the time of enrollment. They already had an oncogenic process going on. And then lastly, in follow-up, you have to ascertain the outcomes, and you have to use a method that is equal in both exposure categories. So remember in a case control study, I said when you go back to find out, ask the cases and the controls if they smoked. I chose lung cancer cases, lung cancer controls, and I wanted to get a smoking history. Remember I said you couldn't interview the people with lung cancer at their bedside when they're inpatients in the hospital and then do the controls on the telephone. I mentioned that the method of data collection should be the same in both groups. Exactly the same with cohort studies. Usually you have the patients at enrollment, but during follow-up, because these studies go on for several years to wait to see who develops the outcome, it's hard to keep track of people. So you want to make sure that both the exposed and unexposed groups are followed in the same way. So if you have patients who are smokers coming in once a year for clinical exams and maybe a chest x-ray to see if they've developed any signs of lung cancer, you need to do the same thing for the controls. And that's very important because if you have an imbalance in your follow-up between exposed and unexposed patients, you're going to detect more outcomes in one group than the other just because you're looking more completely. And so that's going to give you an invalid study result. So sometimes you see the patients, you have hospital records, but frequently in cohort studies, you don't actually always bring every patient in all the time. You use more state and national registries to document outcomes. So cancer registries, frequently a cohort study will look at death as the outcome, so you have death certificates. You all should be aware that there is a system called the National Death Index, which is part of Health and Human Services in the United States. And every person who dies in this country is recorded in the National Death Index. It is a very accurate database, and about probably maybe 10 years ago probably, the government actually went back. It used to be the National Death Index just told you that the patient died and when he died and where his death certificate was filed. But now the National Death Index has been enhanced so that actually electronically every cause of death, which is recorded on the death certificate, is documented in the National Death Index file. So it's a wonderful way to follow up patients in research studies. Okay. Now it gets a little tricky. Okay, so cohort study, exposed and unexposed, follow them forward in time. There's two types of cohort studies, and the naming gets a little weird. So I said a cohort study was prospective in design, and it is. But because there's two types of cohort studies, two versions, we've used different names. And commonly, you will hear people refer to them as a prospective cohort study and a retrospective cohort study. A retrospective cohort study is prospective in design. Hopefully, when I explain this, you'll understand why they've used the word retrospective. The other terminology, which is more today, to get rid of this problem here, is that a prospective study, and I think it's on the next slide, is called a concurrent cohort study. And what used to be called a retrospective cohort study is now referred to as a non-concurrent cohort study. So I said cohort studies take a long time, and they do. And so a prospective cohort study, which used to be much more common many years ago, is that I would start today, smoking and lung cancer. I'd find smokers and non-smokers, and I would have to follow them forward in time. And let's say I took a large enough sample and I had estimated a sample size, so I knew that at the end I would have an adequately powered study, meaning I would have enough people who ended up with the outcome of lung cancer to do an analysis. It would take me 10 years to get that number. So I would need today to follow those subjects 10 years to see who developed lung cancer and who didn't. Think about the Framingham study that we talked about. That is a prospective cohort study. They went into Framingham in 1960, figured out who had high blood pressure and who didn't, and had to follow that group for the next 10, 20, 25 years to see who died of cardiovascular disease. So it takes a long time to do one of these studies. They're very expensive. It takes a lot of effort, and it takes a lot of commitment from the study team, because not only do they have to hang around for 10 or 20 years, They have to make sure they follow all those patients and keep track of them for 10 or 20 years. So that's a big job. And so that's a prospective study. It worked for Framingham, but it cost millions and millions of dollars. And I think you can see that if you had an important research question, this would take a long time to get a research answer. So there are prospective studies going on, but the more common type of prospective cohort study is what we might refer to as retrospective. And with electronic data, this is becoming more and more common. So this means that I would go today, let's say in 2015, I would go back to some database or access to data in 2006. So let's just say that Philip Morris had a database where they surveyed smokers back in 2006 to find out how they liked their cigarettes. And they had identifying information on thousands and thousands of smokers. Maybe I could get approval to access that database and contact those people. I know that they were smokers in 2006. And now, oh, lo and behold, 10 years later, takes me up till today, I can track those individuals down and either interview them and see if they're having any lung problems or have been diagnosed with lung cancer, or if they have expired, I could go to the National Death Index and find out what their cause of death was. So today, I could do a cohort study with 10 years of follow-up and get an answer in, maybe I could do that work in a year or 2 years. So I will tell you that many years ago for my dissertation, I did a retrospective cohort study. Because if I were going to do this, my God, I would never have graduated, right? But I actually went back, I won't tell you the years, but I went back 20 years to the Veterans Administration, who had wonderful electronic records long before before they became popular. And I was able to identify a group of veterans from all over the country who were exposed, who had a particular surgical procedure for ulcer disease, and a group who who had ulcers but were not treated surgically. And I followed them forward in time, so I had 17 years of follow-up and tracked who developed gastric and colon cancer, which was my outcome. So I was able to include in my study 20,000 individuals and then track them for cancer at the time when I was working on my dissertation. So that work might have taken me 3 years, but I had 17 years of follow-up. So it's a very efficient design. All right, so let's talk about more specifically about each of them. So in the prospective concurrent cohort study, like Framingham, we begin with an exposure status that's collected today, the day we're starting our study, and we follow subjects forward in time and examine them for an outcome. This kind of study is best if the disease has a short induction and latency period, meaning you have the exposure, you get the disease, and it's diagnosed within a short period of time. I think the ideal situation or research question to do this kind of a study, I've decided, is for pregnancy. If you want to look at pregnancy outcomes, you only have to wait 9 months, right? You can look at mothers who smoke, or mothers who are on drugs, or mothers who have good nutrition, or mothers who are depressed and non-depressed, and see what are the outcomes of their babies 9 months later. So I think that's a reasonable scenario in which you might do a prospective study, cohort study. But when you're talking about many of our chronic diseases, cardiovascular disease, cancer, you're talking about diseases that have a long latency period, and it makes it hard to do this kind of study. You want to do a prospective concurrent cohort when the exposure is current or recent. So, for instance, I don't know if I mentioned it in here, when there was the nuclear reactor problem in, what's the name of the place where they had the meltdown? In Russia, was it Russia? Chernobyl, thank you, Chernobyl. They went in right after that and started a cohort study of individuals who had been exposed to a lot of radiation, and then a group of people in villages that were further away and were unexposed, because they wanted to follow them for leukemia development, which happens in the next 2 to 3 years after a radiation exposure. So in a situation like that where there's just been a big exposure, that's when you think about doing a prospective cohort study. And you want really high quality data, because you're collecting it, you know what your research question is, and the data are being collected for your purpose. That's the best kind of data, the most high quality, but hard to do. Okay, for the non-concurrent cohort study, as I mentioned, we're going to use a past exposure from previously collected data, and there's the vulnerability. You got to make sure that you can get the data, and it might be there, but is it really, does it have all the bells and whistles that you might have paid attention to if you were collecting it prospectively? And then you have to follow the subjects forward to the present time, or you may be able to follow them a few more years. It doesn't mean you have to end the follow-up when you're at the time you've initiated the study. You can go a few more years forward in time. You want to do this when the disease, it takes a long time from exposure to development of disease, when you can definitely get historical information about the exposure, and when you want to save time and money, like if you're doing a dissertation. Okay, what are the advantages of a cohort study? Well, there's lots of them. First of all, interesting, I used the term cases, didn't I? Oh yeah, the cases of the disease are incident cases, so the outcome, and may be more representative of those who develop the disease than you would get in a case control study. So you're actually following people, and you know they've developed the disease within that short time period. So unlike a case control study, remember we talked about using prevalent cases and incident cases. Incident cases are always better. Because you're following people from an exposure to an outcome, it gives you an opportunity to see what the natural course of disease is. You can get more information about the symptoms, the presentation, the development of the disease that you can't get in a retrospective study. One of the most important things about a cohort study that we don't have in a case control study is that in a cohort study you can actually calculate incidence rates, which we want to know about. And this is a real flaw in a case control study, is that you can't get an incidence rate because you're already starting with people who have your outcome, the disease of interest. Because we can do incidence rates instead of an odds ratio, we're able to calculate something called a relative risk. A relative risk is the measurement of disease risk that you want, but because we can't get that in a case control study, remember you calculated an odds ratio. An odds ratio is an estimate of the relative risk, but the relative risk is the real deal. So there's fewer sources of bias. Anytime you're moving forward in time and controlling the situation, you should have less bias, less risk of bias. And you can now, in a cohort study, you now have a good handle on this issue of temporality. You started with people who had been exposed to something and not exposed and didn't have a disease. And you follow them forward and see who gets the disease. And so it's much easier you have the chicken and then comes the egg. So if you want to address causality, do I think smoking causes lung cancer? Well, I know. I had people who smoked and didn't smoke, and nobody had lung cancer, and there were a lot more people in the smoking group who developed lung cancer than in the non-smoking group. So if you design your study well, a cohort study provides really strong evidence regarding this temporality issue between exposure and disease. Temporality with the next step being causality. And in a cohort study, you're able to study a rare exposure and a common disease. Okay, let's go back to a case control study. Remember, in a case control study, I said case control studies are good if you have a rare disease, a rare outcome. Because you go and you find the people with the rare outcome and you bring them in as your cases, and then you bring a group of similar subjects who are controls without the disease. And then you retrospectively get information about the exposure that you think may be related to that disease. But you have rare outcome, you go for a case control study. If you have a rare exposure, oh, I'm interested in the Chernobyl radiation people. Actually, across the world, that's a rare exposure. So I can go right to that group of people and enroll them in my study as exposed. Or let's say, so we have in Ambler, Pennsylvania, not far from here, we have a superfund of asbestos exposure, and we have extremely high rates of mesothelioma in those neighborhoods in Ambler. Does anybody here live in Ambler? Okay. It's a small area. I could go in, it would be a unusual exposure. I would go into Ambler and I would try to enroll people who live in those particular areas around the contamination. And I would follow them forward in time to see who developed mesothelioma. Okay, what are the disadvantages? Well, I think you probably already got it. The duration of these studies is very long. And it's difficult to maintain the follow-up of patients. You have to have a staff who knows the patients. You need to keep them engaged year after year. That takes a lot of effort. And it also becomes very expensive to conduct one of these studies. You need usually a very large population because you're looking at the occurrence of even common diseases, even cardiovascular disease or a particular type of cancer. Most people aren't going to get that condition. And so you need to bring in a whole bunch of people and follow them forward to get a much smaller number of outcomes. So I mentioned to you that in my study I had 20,000 veterans, 10,000 exposed, 10,000 non-exposed. My primary outcome was gastric cancer. At the end of my study, 17 years of follow-up, I had 46 people who had the outcome from 20,000. So that gives you a sense you need to get data on a huge number of patients, even though you know in the end you're probably going to get a small number of outcomes, which is why sample size estimation, figuring out how many outcomes would I expect, how big do I think this risk is. You have to figure that all out to make sure that even though you have a relatively small number of outcomes, you'll have enough to have your result be statistically significant if it's clinically important. Mine was. Okay. So large population. You, I think, hopefully will be entertained by the fact that I did my dissertation before you could get the cause of death from the National Death Index. So I used the National Death Index to find out who died. I had to go to, these are the wonders of technology now, I had to go to every state in the United States and Puerto Rico, to the state health departments, and request copies of the death certificates of everyone who died. So out of my 20,000 people, I had almost 10,000 people who were dead. So I literally had 10,000 death certificates in my living room. And then I had to go through, I didn't do it, I had a professional coder who was trained to code the causes of death that were recorded on the death certificate. You don't have to do that stuff anymore. And of course, when I think back, of course I had IRB approval from every state, but probably they wouldn't have been happy if they saw those death certificates sitting on my dining room table. So we do better now. The exposure may not have been measured at baseline or may change. We talked a little bit about that. Rare diseases cannot be studied. Rare exposures for cohort studies, not rare outcomes, or you'll never get enough. And you can still have several types of bias in a cohort study because it's still observational, and these could cause spurious associations. So an example of, here I am telling you about how wonderful a cohort study is, and now I say, well, there's bias. A cohort study is really a good study, but unless you are going to experimentally randomize patients to one's treatment or another, there are always a multitude of factors that are associated with someone falling into one group or the other. So sort of a seminal example of this is the work that was done 10 years ago on hormone replacement therapy in postmenopausal women. So it used to be many of your grandmothers and maybe some of your moms, probably grandmothers, all, as soon as they became menopausal, they were put on hormone replacement therapy. And all the observation, there are huge cohort studies that have been done that showed women who took hormone replacement therapy had longer survival, decreased mortality, and less cardiovascular disease than women who didn't take hormone replacement therapy. So then some data came out that looked a little, this estrogen thing. Estrogen has a lot of negative effects on different tissues in the body. And there was always a little worry or surprise about this result. And numerous cohort studies showed that hormone replacement therapy was a good thing for women. And then the NIH did the Women's Health Initiative, which did a national, very, very large trial that experimentally randomized people, postmenopausal women, to either get hormones or not get hormones. And in fact, that study was stopped early because there was an increased risk of cardiovascular deaths in the women on hormone replacement therapy. It was exactly opposite from numerous cohort studies. And that shows the bias of a cohort study. So what was the problem? What couldn't we control in a cohort study? We couldn't control the fact that the women who were taking the hormone replacement therapy were the women who had good access to health care, could afford to buy their hormone replacement therapy, or it was paid for by a good insurer. And hormone replacement therapy was the thing that was going to keep women young and sexual and good skin and all those things. And those were the same women. They'd take their hormone replacement therapy and then they'd go to the gym and work out. And then they'd go eat a nutritious lunch. So you couldn't control all the other, the matrix of behavioral factors that really described a woman who happened also to be a woman who wanted hormone replacement therapy. So I think that was a lesson for the world that as good as cohort studies are, until you do a randomized trial, you can't be positive that you got the right answer. Okay, let's talk about how we're going to summarize this risk that we're trying to identify in a cohort study. So this table should look familiar to you. Remember, last week it was cases and controls. Now it's a cohort study. So we start over here. We choose exposed and non-exposed. We follow them forward in time and determine how many get the outcome of interest and how many don't. If you look across the row, A divided by all the people who are exposed would be the incidence rate of disease in the exposed group, and C over C plus D is the incidence rate of disease or outcome occurrence in the non-exposed group. And so we now calculate a relative risk. So this is in place of an odds ratio. Remember AD over BC. For a relative risk, which is a much better, less biased estimate, we take the incidence of disease in the exposed divided by the incidence of disease in the non-exposed, and that gives us a relative risk. And for the relative risk, it actually is interpreted exactly like an odds ratio, not the literal, but the second kind of the second interpretation that I taught you that you'd say to patients. That really is the interpretation for a relative risk. So if I have a relative risk of 1, that implies the risk of the outcome is similar in the exposed and the unexposed, meaning there's no association between smoking and lung cancer. If the relative risk is greater than 1, then there is a greater risk in the exposed than the unexposed, suggesting a positive association usually. And if the relative risk is less than 1, which as we're doing more health promotion research, we used to only study bad things, so we got relative risks over 1. But now as we're looking for things that prevent disease, you begin to look for relative risks that are less than 1, showing that the risk in the exposed group is less than the risk in the unexposed, meaning you have some protective factor. So if you eat a nutritious diet versus a non-nutritious diet, you would expect that among those eating a nutritious diet, your relative risk of a particular disease might be less than 1 because you should have less disease outcome if you eat well. Okay, so this again is the table. Here's a little example. So if we were looking in a hypothetical cohort to examine the relationship of smoking and coronary heart disease, we have smokers and non-smokers, and we, excuse me, here we enrolled a group of people and then interviewed them and found out that 3,000 of them smoked and 5,000 didn't smoke. And over the course of follow-up, we had 84 events among the smokers and 87 in the non-smokers. And so you calculate the incidence in each group. 84 divided by 3,000 gives you 28 per 1,000 per year, and 87 over 5,000. And so these are your incidence rates in exposed and unexposed. And when you take the ratio, you get 1.61. So my interpretation here would be there is a 60% increase in risk of coronary heart disease among smokers compared to non-smokers. Questions on that? We okay? Okay. So when do we do a prospective study? You don't do it until you have good evidence that there is an association between exposure and disease. So you don't come up with a research idea and say, hey, I think I'm going to do a cohort study. You would go back and say, oh, maybe there's some ecologic data I could get. Maybe there's a cross-sectional study I could do. And you'd build down that series of trials. And if everything begins to look like there could be an association, then you commit to a prospective study, meaning usually a cohort study. But because they're so expensive and take a lot of work and a large number of subjects, you don't do it until you have some inkling that you're on the right track. You only do a cohort study or a prospective study when you can maintain contact and follow up with your study population. You want to minimize attrition. If you lose more than 5% of your sample in follow-up, your study is going to be biased and you'll never get it published in a good place and people won't pay attention to it. So minimizing attrition is always a major issue in a prospective study. You need to have ample funds. Usually this comes with grant funding because they're very expensive. And if you're doing a concurrent approach, you need an investigator who has a long life expectancy because they're going to have to do this for their entire career before they have an answer. Okay, so let's look at a quick example here. I think in some of the observational studies, I used vitamin D deficiency and bone fractures as an example. So let's say, and we talked about a case control study where we might take people who had women who had a fracture and women who didn't have a fracture, and the exposure would be vitamin D deficiency. We'd check to see if there was a greater percent of women with fractures who had low vitamin D compared to women without fractures. That would be a case control. Now, how would we and let's say we found that association. We now may say, let's move on to a cohort study to study this association. And so now I'd have to pick people who are exposed and people who are unexposed. So I might take people who I know had a battery of blood tests and it has been identified that their vitamin D is low, and a group of women who have normal vitamin D. So maybe I'd get them from hospital records. And then I would want to follow them forward in time to see who developed a fracture. And I'd have to define what kind of fractures am I interested in. Any fracture, a hip fracture, a radial fracture, that would all have to be defined. And in the end, I would be able to put together a 2x2 table like this. I identified 1,000 women who had low vitamin D and 1,000 women with normal vitamin D. Here's the number of fracture events that there was over follow-up. I've calculated an incidence rate, and the relative risk is the incidence in the exposed divided by the incidence in the unexposed, which gives me a relative risk of 2.5. Women who have, so the conclusion would be, for women who have a vitamin D deficiency, they have 2.5 times the risk of a fracture as women who have normal vitamin D. Okay? They do not have a 250% increase. They have a 150% increase. You have to subtract the 1. So really, you should just say their risk is 2.5 times that of individuals with a normal vitamin D. The wording can be tricky. Okay. One last thing I want to say. I know I'm running late. I just want to quickly bring up the point of a nested case control study. This is a kind of cool design where you can do a case control study because they're very efficient, but you use the framework and the strengths of a cohort study. So if you think about that Framingham study that I talked about, where they took individuals who had hypertension, and they followed them forward in time to see who developed cardiovascular disease and who didn't. They were following those individuals and collecting all kinds of health information on them. So what if I now go back and say, gee, I think I have a biomarker that is predictive of breast cancer. I could go back to Framingham and say, how many cases of breast cancer do you have? I could pick a random sample of individuals in the Framingham study who did not develop breast cancer. And I could then ask, in these people who have the outcome, cases and controls, would Framingham give me a sample of their sera from their biorepository that is available in Framingham? And I could go back, and the exposure would be an elevation in this biomarker that I think predicts who gets breast cancer. So I could do a very clever case control study looking at the association between my biomarker and risk of breast cancer, but it has the strength of a prospective study because I know the biomarkers were collected, the blood was collected before the patients developed breast cancer. So it's an efficient way to make use of a cohort study and do a quick and high-quality case control study. So I'm going to stop there. Remember, cohort study is the first prospective study that we talked about. And anytime you're moving forward prospectively, you're always in research going to be better off than doing a retrospective study. Okay, questions? Okay, I will see you guys Friday, and we'll go through a workshop on this, okay? Thank you.
Blood cells that help fight